I want you to think about the advice, or really just the cultural narrative that we're all fed about what happens to a body after someone gives birth.
Right, yeah. It's everywhere.
It is. And the common assumption is always that things get stretched out to their absolute limit and basically stay, well, loose.
Yeah, like this inevitable permanent structural failure.
Exactly.
Yeah.
But what if we have this entirely backwards? Like, what if the intense pain, the numbness, and the discomfort experienced postpartum isn't actually a sign of laxity at all, but the exact opposite?
Well, we constantly see this assumption in clinical practice. I mean, human beings prefer binary explanations, right?
Sure. Yeah. Tight is good, loose is bad.
Exactly. When things feel different after a major physical event, it's comforting to have a simple, visible explanation.
But the moment you actually step into the world of postpartum pelvic health, that simple explanation just completely falls apart.
It really does.
So today, we are opening up a massive stack of clinical guidelines, physical therapy resources, and current medical literature to uncover what is honestly a huge misconception.
It's a really important one, too.
Yeah, so the mission for this deep dive is to investigate a very specific question. Can pain after childbirth be mistakenly blamed on laxity?
And we're going to look at how this simple, seemingly logical misunderstanding is leading to completely wrong and sometimes, frankly, incredibly painful treatments.
Right. So to truly understand how this misdiagnosis happens, where do we even start?
Well, we have to start by setting a physiological baseline. We need to look at the sheer biomechanical feat of a vaginal delivery.
Okay, lay it on us.
So the clinical sources detail how the vaginal canal must expand up to 4 times its resting width just to allow a baby to pass.
Okay, let's unpack this. Because going from a resting state to 4 times that width, that defies how we think about our own anatomy.
Right, it sounds impossible.
Just picturing that expansion, it's no wonder people assume they're dealing with permanent looseness. If you stretch anything 4 times its size, you totally expect it to lose its elasticity.
Yeah, and because of this incredible stretching, many women complain to their doctors of exactly that, vaginal laxity.
Right. They describe a feeling of looseness or a lack of friction during intimacy, or even that symptom of vaginal wind.
Which the medical literature very politely terms the auditory passage of air.
Right. Very polite, but they feel like the whole structure has just given away.
And the sensation those patients are feeling is entirely real. We can't discount that.
But the literature says otherwise.
Well, it reveals that their assumption about why it feels that way is where the error occurs. Because this isn't just a passive stretching process, it is active, acute trauma.
Like the tissues are actually wounded.
Yes. If we look at the reality of spontaneous perineal tears, we are not talking about a minor surface graze.
No, definitely not.
The medical guidelines classify these tears into 4 degrees of severity.
Okay, walk us through what that actually means structurally, because I think people gloss over this.
So in a first-degree tear, only the superficial skin of the perineum is injured. That's the most minor.
Okay, skin level, got it.
But by a second-degree tear, the underlying muscles of the pelvic floor are actively tearing.
Oh, wow. So we are already into the muscle.
Right. And a third-degree tear extends even further, involving the tearing of the anal sphincter.
Okay, that sounds incredibly painful.
And then in a fourth-degree tear, the patient suffers a complex rupture involving both the internal and external anal sphincter.
Wait, tearing through the actual sphincter muscle? That is major visceral trauma.
It's a severe muscular injury. It's not just stretching.
Yeah, and that doesn't even account for intentional surgical cuts, right? Like episiotomies or the trauma from vacuums and forceps.
Exactly the point the physical therapy resources make. We are dealing with living muscle and complex nerve networks, specifically the levator ani muscles and the pudendal nerve.
And living tissue reacts to trauma. Like it defends itself.
It does. The data shows that anywhere from 23% to 43% of women continue to experience localized pain and discomfort 10 to 12 days postpartum.
And some have it for much longer.
Yeah. Up to 10% have long-term pain 3 to 18 months later. Wounded tissue does not just hang there lifelessly.
It responds the way wounded tissue anywhere else in the body responds to a severe injury. Which brings us to a massive plot twist in these sources. The way that wounded pelvic tissue responds is by guarding.
Right, the guarding response.
So instead of becoming this stretched, open, relaxed void after birth, The pelvic floor muscles often do the exact opposite.
Go into a state of self-protection.
Yeah, they clench up and they just refuse to let go. So it's easy to think of the pelvic floor like a rubber band that's been stretched too far and lost its snap, right?
Yeah, that's the common analogy. But what's fascinating here is that unlike a dead rubber band, we're talking about living muscle. The clinical term for this clenched state is a hypertonic pelvic floor.
Okay, hypertonic. Break that down for us.
Hypertonicity basically means the muscles are excessively tense. They're holding entirely too much tone, and they literally lose the mechanical ability to relax.
So they just get stuck in a non-position.
Exactly. And there are several mechanisms driving this. The acute physical trauma is the primary driver, especially scar tissue.
Oh, right. Because scars aren't flexible.
Exactly. When a second, third, or fourth degree tear heals, or an episiotomy heals, it forms a rigid scar. And that scar acts like an inflexible anchor inside the pelvis.
And that anchor pulls on the surrounding healthy muscle fibers, right? Triggering them to spasm.
Yes, but the sources also mention this can happen even without a severe tear.
Really? How does that work?
Well, hypertonicity can also be triggered by the sheer postural changes of the postpartum period.
Oh, I guess that makes sense.
Yeah, think about constantly carrying a growing infant. Your center of gravity shifts forward.
Right, so to keep you from toppling over, your pelvic floor and lower back muscles just have to clench continuously to compensate for that new unbalanced load.
Exactly. Add in the chronic emotional stress and sleep deprivation of having a newborn.
Which is a lot.
It really is. And that keeps the nervous system locked in fight or flight, and those muscles simply never get the signal to stand down.
Wow. I want you to imagine the profound confusion this causes for the person actually experiencing it.
It's incredibly frustrating for them.
Right, you go to your doctor, you say you feel loose because friction is gone, or things feel numb or heavy. But structurally, under the surface, your muscles might actually be dangerously, painfully tight.
Yes.
So if I'm the patient, how do I even know if I'm dealing with true laxity or if I'm trapped in this hypertonic grip?
Distinguishing between the two is a critical diagnostic step, and the physical therapy guidelines actually provide a clear clinical rule of thumb for this.
Okay, what's the rule?
Well, weakness, which is hypotonicity or true laxity, typically presents as painless dysfunction.
Painless. Okay, that's a key word.
Right. The classic sign is stress incontinence.
Mhm.
So painless urinary leakage when you laugh, cough, or jump. It can also present as a heavy dragging sensation, which might indicate pelvic organ prolapse, where the bladder or uterus bulges into the vaginal canal.
Because the weakened muscles simply cannot hold them up against gravity.
Exactly.
Okay, so weakness is generally characterized by painless leaking or a structural heaviness.
Yeah.
How does tightness present differently?
Tightness, the hypertonicity, presents primarily as pain.
Okay, so pain is the major red flag.
Yes. We're talking about active pelvic muscle spasms, painful sex, which is clinically called dyspareunia, pain with tampon insertion, or even severe discomfort during a standard gynecological exam.
That sounds awful.
It is. And furthermore, it frequently presents as urinary urgency and chronic constipation.
Wait, let's explore that mechanism for a second. If the muscle's too tight, why does that cause urinary urgency or constipation? Shouldn't a tight muscle keep everything perfectly contained?
You'd think so, but think of the pelvic floor like a functional doorway.
Okay, doorway.
If the muscles are in a hypertonic spasm, they are essentially holding the door shut so tightly that the hinges are vibrating.
Oh, man.
When the bladder signals that it's time to empty, the pelvic floor must actively relax to open the door. But a spasming muscle cannot relax.
So the patient feels desperate urgency because the bladder is full, but the pelvic muscles are just too clenched to allow a smooth release.
Exactly. The same mechanism causes severe constipation. The mechanical release simply cannot occur.
It's like the muscles are locked in a cramp.
Right.
And this is where the narrative we discussed at the beginning becomes actually dangerous.
Yeah.
Because if a patient assumes they are just loose after birth, and they mention this at their standard 6-week checkup, what happens?
Well, the universal knee-jerk medical advice they receive is just do your Kegels.
Yes, the dreaded Kegel. The generic prescription of Kegel exercises is honestly one of the most frustrating aspects of postpartum care highlighted in these sources. Because if your pelvic floor is already in a state of hypertonic spasm, doing Kegels is like taking a bicep that is currently locked in a painful Charlie horse and actively trying to curl a 30-pound dumbbell, right?
That is the exact biomechanical reality, yes.
You are taking a muscle that is begging for relief and forcing it to work harder.
Prescribing Kegels for a hypertonic pelvic floor drastically exacerbates the pain. You are just fueling the spasm.
And it gets worse, doesn't it?
It does. Beyond that, the physical therapy literature highlights a staggering diagnostic statistic. Up to 30% of women perform Kegels completely incorrectly without realizing it.
Wait, really? 30%?
Yes. Instead of drawing the muscles upward and inward, they bear down. They push outward, as if they were trying to stop a bowel movement.
Which puts even more intense downward pressure on tissue that is already traumatized and vulnerable.
Precisely. It actively works against the healing process.
But here's the cascade effect of that bad advice. When the Kegels inevitably fail to fix the issue and the pain or the feeling of looseness persists, women become desperate.
Understandably so.
Right. They think their bodies are permanently broken. And that desperation opens the door to an entire, highly lucrative industry of aggressively marketed treatments. I'm talking about vaginal rejuvenation.
Yes. The clinical guidelines from major medical bodies are incredibly stern regarding this topic.
What do they say?
Well, vaginal rejuvenation is a marketing term. It is not a recognized medical diagnosis or standard clinical procedure. We really must delineate between legitimate medical therapies and predatory aesthetics.
Right, because there are real treatments out there.
Yes, there are non-surgical laser treatments, such as CO2 or erbium lasers, that utilize thermal energy to stimulate collagen production in the vaginal mucosa.
Okay, so those work?
They have proven clinical efficacy, yes, particularly for treating menopausal vaginal atrophy where the cellular tissue has genuinely thinned out due to age.
But that's not how they're being marketed to postpartum women. We are seeing things like the O-shot or the G-shot, where they inject blood plasma to supposedly plump and tighten things up, or lasers marketed as a magic wand for postpartum laxity.
And the British specialist societies and international gynecological boards issue very strong warnings against this trend.
What's their main concern?
They highlight that aesthetic surgeries, such as labiaplasties, aimed at achieving what the literature bluntly calls a Barbie doll look.
Wow, they actually call it that.
Yes, they do. These are frequently sold using pseudoscientific claims. They prey on a fundamental misunderstanding of postpartum anatomy.
And clinically, it makes zero sense. I mean, if your pain and your lack of sensation are being driven by a hypertonic muscle spasm, going in and surgically cutting or laser tightening the mucosal tissue to make the canal physically smaller, that does absolutely nothing to stop the underlying muscle from cramping.
It completely ignores the functional pathology. You simply cannot surgically excise a muscle spasm.
Right. But here's where things get incredibly fascinating. Because as we dug deeper into the sources, we realized that beyond the muscle tension, the scarring, and the misapplied treatments, there are entirely invisible culprits causing this sensation that gets blamed on laxity.
Yes, the unseen factors.
We have to look at the chemical and neurological landscape. Let's talk about the hormones, because the literature highlights a physiological reality of breastfeeding that is rarely discussed.
It's a huge factor.
Producing milk essentially puts the body into a temporary, chemically induced state of menopause.
It is a profound systemic shift. The medical term for the pain it causes is lactational dyspareunia.
Okay, break down the biological mechanism there.
It's fascinating, really. The hormone prolactin, which stimulates breast milk production, actively suppresses the ovary's production of estrogen.
And estrogen is important here because
estrogen is the primary hormone responsible for maintaining the thickness, elasticity, and natural lubrication of the vaginal tissues.
So when estrogen plummets because you are nursing, what happens locally to that tissue?
The cellular structure actually changes. Without sufficient estrogen, the vaginal walls become thin, pale, and incredibly fragile.
Oh, wow.
Yeah, they lose their stretch, and they stop producing moisture. This is temporary postpartum vaginal atrophy.
I want to focus on how this feels to the patient. Because if you attempt intimacy in this state, the total lack of natural lubrication causes intense burning friction.
Yes, it can even cause micro tears in the tissue.
But if nobody has warned you about this chemical estrogen drop, how do you interpret that sensation? You feel a lack of normal friction, you feel intense discomfort, and you immediately think, my body is ruined. I am permanently stretched out and loose.
Exactly. The patient misinterprets a severe hormone-driven moisture deficit as a structural anatomical failure.
It makes total sense why they'd think that.
It is a completely logical yet entirely incorrect assumption based on the physical sensation of friction versus glide.
It's a chemical problem masquerading as a structural one. And that brings us to the second invisible culprit in the sources, which absolutely blew my
The
mind.
neurological aspect.
Yes, the clinical text details something called temporary pudendal neuropathy.
This is a critical piece of the puzzle. So the pudendal nerve is the primary sensory and motor nerve network supplying the pelvic floor. During the second stage of labor, which is the pushing phase, this nerve is subjected to immense mechanical stretching and compression.
Wait, so the nerve itself is being crushed under the weight of the baby.
Stretched, compressed, and sometimes partially damaged. And as a result, the nerve becomes temporarily stunned.
Stunned. What does that mean functionally?
It loses its optimal ability to send and receive clear neuromuscular feedback between the brain and the pelvic floor.
Oh, I see. It sounds like the pudendal nerve gets stretched, causing the Wi-Fi connection between the brain and the pelvis to drop.
Yeah.
Like the router is on, the computer's on, but the signal just isn't making it across the network?
That is an excellent way to visualize the mechanism of temporary neuropathy.
Because the nerve is stunned, the patient experiences a drastic, localized reduction in physical sensation.
Exactly.
But again, think about how the patient interprets that. They feel numb.
Yeah.
They feel like nothing is happening down there, so they assume the tissue is just gone, or it's so loose that it's beyond repair.
But structurally, the muscles might be perfectly intact.
The brain and the pelvic floor just temporarily cannot communicate.
Right, the physical structure is just waiting for the neurological connection to reboot.
Okay, let's synthesize where we are. We've established that the pain, the numbness, and the persistent feeling of being loose are highly likely to be a combination of muscle guarding, rigid scar tissue, hormonal dryness, or this neurological Wi-Fi lag.
It is rarely just permanent, unfixable structural laxity.
So how does the medical literature actually suggest fixing these complex mechanisms? If blind Kegels and cosmetic surgeries aren't the answer, what is?
Well, the clinical approaches detailed in the physical therapy literature focus heavily on functional restoration rather than structural alteration.
Okay, what's an example of that?
One of the primary diagnostic and therapeutic tools is the use of biofeedback devices.
How does that actually work mechanically? I mean, if a patient can't feel the muscle because of that dropped Wi-Fi signal, what does biofeedback do?
It provides an external visual substitute for the internal sensory loss.
Visual substitute, like a screen.
Exactly. Small sensors are placed on or inside the pelvic floor, and these sensors measure the electrical activity of the muscles.
Okay.
The patient watches a screen that displays a graph of their muscle tension. When they try to contract, they can see the graph spike.
Oh, I love that.
But more importantly, when they try to relax, they can visually verify if the graph returns to a flat baseline.
So it bypasses the stunned nerve and lets the eyes tell the brain what the muscle is doing, retraining that connection until the nerve physically heals. That is brilliant.
It's highly effective.
But the sources also talk about totally non-technological solutions that seem counterintuitive, like to fix the feeling of looseness. Patients are taught to actively relax through diaphragmatic breathing.
Yes, to understand why breathing works, we have to look at the anatomy. The respiratory diaphragm, which is the muscle under your ribs, and the pelvic floor work together in a synchronized system.
Like a team.
They operate like a piston.
Walk us through that piston mechanism.
Okay, so when you take a deep, proper diaphragmatic breath, your lungs expand and push your diaphragm downward.
Right.
This downward movement pushes your abdominal organs down, which places a gentle physical pressure on the pelvic floor.
Okay, so it pushes everything down.
Yes, and that pressure forces the spasming pelvic floor muscles to yield and stretch downward.
Oh, I see.
And then when you exhale, the diaphragm moves back up and the pelvic floor recoils upward. By forcing the patient to focus on deep, expansive inhales, physical therapists can mechanically force the pelvic floor out of its hypertonic clench.
That's so cool.
And furthermore, this type of deep breathing stimulates the vagus nerve, which shifts the entire nervous system out of the fight-or-flight state that causes the muscle guarding in the first place.
So you are basically hacking the nervous system to force the muscle to let go.
Exactly.
What about the physical anchors we talked about, the rigid scar tissue from tears and episiotomies?
That requires specialized manual therapy, specifically connective tissue and scar tissue mobilization.
Which is basically massage, right?
Yes, a pelvic floor physical therapist uses targeted internal and external massage techniques to gently break down the adhesions in the scar tissue.
Okay, so they physically loosen the tight spots.
By physically stretching and desensitizing those rigid areas, they remove the anchor that is constantly pulling on the healthy tissue.
Which stops the surrounding muscles from reflexively spasming.
Exactly.
And finally, for the chemical side, the temporary menopause of breastfeeding and that severe lack of estrogen.
Clinicians frequently utilize highly targeted topical estrogen creams or hyaluronic acid moisturizers applied directly to the vaginal mucosa.
Is that safe for the baby if they're breastfeeding?
Yes, because it is topical, it treats the localized cellular atrophy and restores the tissue's thickness and elasticity without introducing systemic estrogen into the bloodstream, which is safe for milk production.
Oh, that makes sense.
And it resolves the friction that the patient is mistaking for laxity.
Wow. So what does this all mean for you, the listener? It means that if you or someone you know is experiencing pain, discomfort, or a persistent feeling that the body is just structurally wrong after childbirth, the absolute worst thing you can do is suffer in silence or try to self-diagnose based on a commercial for a cosmetic laser procedure.
Absolutely.
Your pelvic floor is an incredibly complex, living hammock of muscles, active nerves, and reactive connective tissue. It requires functional assessment by a professional, like a pelvic floor physical therapist, rather than just assuming your body is permanently loose and broken.
If we synthesize the core message across all of these medical guidelines, it is this. The postpartum period leaves the body neurologically and biomechanically vulnerable.
Incredibly vulnerable.
What is clinically interpreted by the patient as permanent laxity is, more often than not, a protective mechanism. It is a complex presentation of hypertonic muscle spasms, inflexible scar tissue, stunned nerves, and acute estrogen depletion.
So it's everything but being just loose.
Exactly. Treating that complex pain by blindly trying to tighten the structure, whether through frantic, misguided Kegels or invasive cosmetic surgery, ignores the pathology and usually exacerbates the true problem.
Right.
The body is stuck in a protective, guarded state. The clinical goal is to help the nervous system and the musculature feel safe enough to finally let go.
That structural reframing changes the entire conversation around postpartum recovery. Thank you for joining us on this deep dive. I want to leave you with a final thought to mull over, building on the mechanics we've uncovered today.
It's a really interesting point to consider.
Yeah, we talked extensively about how the trauma of childbirth can cause that temporary pudendal neuropathy, that dropped Wi-Fi signal where the brain and the muscle stop communicating, leading to numbness and protective spasms.
Right.
It makes you wonder, if childbirth can cause such profound, hidden changes in how our brain communicates with our muscles, how much of the chronic, unexplained physical pain we experience in other parts of our bodies might actually be a dropped neurological signal between our nervous system and our tissues, rather than the permanent structural damage we always assume it is.
That's a great question to leave on.
Keep questioning the narrative. We'll catch you next time.